I think the people are already waiting online, ladies and gents. So I think we're going to start with our session. Right, our first speaker is also an absolute legend in this part of the world, Dr. Villi Breitenbach. He's actually the head of clinical unit of pediatrics at George Hospital. And this is actually one of his interests. So Villi is a man of many talents, and he's always approachable. He's a great friend of ours at the hospital. Like Mira, one of my colleagues said, after an M&M with Villi and his team, we actually feel a lot better when we go out of that session. So welcome, Dr. Breitenbach, and he's going to talk to us on the child with developmental delay and intellectual disability.
Thanks, Simon. Those are big words. I feel like a pleb standing here with all the pros looking on. So I have to see how this goes. If I make a really stupid comment, please feel happy to change me afterwards. Yeah, so just credit for the talk information shared is my colleagues and specifically Dr. Joseph Alt. A few years ago, I attended a conference at Professional Minds, and that was very insightful. And then I got some information also from Up to Date. So developmental delay in 15 minutes. When I think about a baby in a womb, it's all curled up in a little ball. And this baby then have to go from this ball that's curled up, all in flexion after being born, to I'm standing like extension now, and yes, one day we will be curled up again. But it's a process that involves head control and gross motor, thorax muscles, head control, able to look. With that vision and eye contact following and smiling, starting to make sounds. You see the baby in front of you lying there, and you pull up and he starts using his head more and more, kicking, exploring more and more with his hands. And you find the extensors more and more working towards the point where he can sit. And at that stage, it should be the primitive reflexes should be disappearing. And then at 9 months, he starts crawling and standing against objects about 1 year, walking and single word sentences in the first year, or single words in the first year, 2 word sentences the second year, and 3 words sentences the next year. So just give you that picture. So the domains of development, you can say there's many ways, but the hearing, speech, social interaction, motor would be gross and fine, using his hands and fingers from 1 year onwards, vision, and then cognitive behavior. So why do we need to identify developmental delay? Well, if there's a possibility of a child with developmental delay, we really want to make a diagnosis, is it true or not? We want to avoid, if we do think it is, and we can think of causes, we want to avoid costly investigations. We want to determine how severe it is, associated problems. Children with CP can develop contractures, and treatment options. The risk of recurrence, can we prevent recurrences, and what is very importantly the main concern for the parents. And so early identification and therapy aims is to promote independence of the child, to prevent secondary complications, like I mentioned, to improve function, and especially parent empowerment. So if you ask caregivers, this is from the studies, if they have concerns about their child's development and behavior learning, studies suggest that parents estimate if they think there's a problem, there's an 83% chance of being correct. So you really need to listen to them if they have a concern. The lack of concern, though, does not exclude it. So we still need to be open-minded on that. So back to normal development. and I'm not going to go more detail because you have these tables that's really available that you can look at. So let's maybe, and it's, I mean, you can, it's really looking on the internet, you'll find many, but maybe looking at some warning signs. And that is, if I take the same baby, if it's got marked hypertonia or marked hypotonia, if you see asymmetry in his reflexes and his movement, if there's poor sucking, this is especially in the newborn, but some of these continue onwards. If it's by 6 weeks, not fixating, following, if there's excessive head lag, if there's failure to smile, not responding to the mum's smile. We're still in the first 3 months, still strong extension of the head, your trunk and hips when place sitting, when the lower extremities are not kicking but strongly extended. When there's no attempt to lift the head at 3 months, no hand-body exploration. And I could go on, but it will take really the whole talk. And this is available actually in the Road to Health booklets. We have these tables, and we have to make the effort when we see children use such opportunities to mark and to see if they tick the boxes. And if not, then refer. So when you think there is a problem, you need time, and 15 minutes is not long enough. So you need to get a good history, examination, special investigations come to mind, trying to make a diagnosis and your management. And the history is family, environmental, antenatal, pattern of development regression, and pattern of behavior. So the family history, very important, 3 generations, go back, mums and grandmums. Any other children that's handicapped, as it boys, could be X-linked, like they've got your fragile X, but the Duchenne's could be coming in there. Think of dominant conditions, tuberous sclerosis and neurofibromatosis. I think ask the question if mum and dad is in a way relating to each other. Could be multifactorial, and then of course substance abuse is a very important one to consider. Any smoking in the family. I don't think we're testing for lead poisoning enough, but that's certainly something to consider in environmental, and then radiation is if the mum has had any exposure. Antenatal things still, nutrition of the mum, this is on the mum side, trauma and stress in the pregnancy, that definitely leads to a stressed baby. Medication, drugs, epilim are one, alcohol is another, as you know. The ill health of the mum, if she's got chronic infections, that will affect the baby. Are they twins? And the very important question, what was the antenatal movements like? This is a big one, gestational age prematurity. We see a lot of problems related to premature babies. They can develop all kinds of problems, ventricular bleeds. They can develop periventricular leukomalacia, where you've got spastic diplegia. What was the APGAR like? Was there resus and any signs of HIE? Any other complications around the birth and neonatal period, like prolonged jaundice, prolonged stay in the hospital? Any hypoglycemia, infections, you're thinking meningitis, any seizures? And then the head circumference. One of the things that I would like is if you chart a term baby and you get a head circumference of 30 centimeters, it would be great if that could be double checked by someone else and both people sign, because it's a very important finding in a term baby. A head circumference of 30 or 31 is really a small head, which implies that there might have been an antenatal incident, because the brain grow as the babies, the head circumference, head grow as the baby's brain grow. So if baby's born with a small head, then there's a real worry. Was there antenatal incident that has caused problems? Okay, so other conditions to consider is your gastroenteritis leading to severe hyponatremia, CNS infections. This is post the neonatal period, like meningitis. Child with chronic ill health will be delayed, and then epilepsy syndromes. And the big one that we probably see the most in the young ages is West syndrome, where these children present and they could be normal until a certain age, and then they suddenly start with flexion episodes, we call infantile spasms. And it's very important to recognize they would have specific EEG changes, and often if you leave them untreated, they end bad. Even with treatment, they can have a bad neuro outcome. The pattern of development, Villi, is a child that initially is very floppy, hypotonic, non-feeding, and severe failure to thrive, and then they start eating, and often they end up then fat and short. Are they regression? The Rett syndrome is one of those where the child develops normal, and then the head circumference stops growing. They very fidgety with the hands, and they regress in neurodevelopment, and they start having seizures, and the outcome is usually bad. It mostly affects girls. About 2 months ago, I saw a child in Mossel Bay that had a child walked in and looked really like an autistic child, and then the story was that mum said he was fine and he stopped doing all this stuff, and so we have been sending that child for scans and workup, and from the first imaging, it really looks worrying that he might have an underlying metabolic condition. Other patterns is Williams syndrome. We have a cocktail champagne personality. I mentioned slow to walk but speaks well in really small prem babies where they have spastic diplegia, where the rest of the brain is unaffected. And then skills and weaknesses, autism I mentioned, children with that's really good at puzzles, but they're in their own world, not making eye contact and not playing and having a really poor social interaction. So associated problems to consider are the seizures, any eating problems, stool or urine problems, any other infections. Children, we've had a few now with cerebral palsy that get pneumonia, and what is the visual and hearing like. So on my examination, you need to spend really time in just watching and observing. See the child adjust to the setting, his social interaction, his speech, his activity, his posture, tone, movements. Are there any abnormal movements? And then what I've certainly learned in the last few years is if you have a small baby that you're not knowing what's going on yet, compare him with the other. We were in the ICU a few months ago, and there was a baby that ended up with a spinal muscular atrophy, and this baby was it was just not normal. And in the same bed was another baby with bronchiolitis, and when I looked at the two, suddenly it struck me, that baby is normal, and this baby is definitely something seriously wrong. And it's really good to, if you have, can look at ways to compare them. Other things in the examination is, are they dysmorphic findings? Babies that's too small, you're thinking prematurity, fetal alcohol syndrome, some genetic conditions. The severe hypotonic infant, are they upper motor neuron signs that you think brain problems? Spinal could be upper motor, lower motor, neuromuscular junction, lower motor, muscular would be lower motor signs. And I mentioned Villi. One important one to consider, and any child with developmental delay, if you talk testing to do, is definitely for thyroid functions. Causes of microcephaly, I mentioned congenital causes. Incident in hypoxia in the brain as an example, but they could be familial. And then I mentioned the head size at birth is really important. Are there infections? Are there trauma? You've all seen the child with HIE that has a normal brain, normal head circumference, and then the head circumference just stopped growing, and I mentioned Rett syndrome. Macrocephaly, potential causes there. One is familial. Hydrocephalus is a big one to exclude. You can have chondroplasia and thalassemia where the bones is prominent. Big brains would be conditions like Alexander's or Canavan's, and then autism and Fragile X, about 75% of them would have actually macrocephaly. Look for skin changes, and especially thinking of neurocutaneous syndromes. The vision, can the child see? Are there any cataracts? What is the light reflex like? And then a really thorough a systemic examination with, of course, the focus on a full neurological exam, which I'm not going to spend further time on. Putting it together is then the challenge. Is there an incident? Is this a static thing? Is this an ongoing process like regression? Could there be a cause? Is this genetic cause here? Is it upper motor and lower motor regression? Is it there? Important treatable conditions is definitely thyroid is up there, galactosemia. Children that's severe jaundice at birth, they might have cataracts. Hydrocephalus is, of course, to exclude. Craniosynostosis would be a child with a small head where the bones are fused, and that we need to identify them. And then underlying infections like HIV and syphilis. As a registrar, I saw a kid of about 10, 11 with blindness, and he had neurosyphilis. So just think wider. Investigations can become really wide, and you need to be guided by what you have on doing that. If you think it's seizure disorders, then EEG or CT scanning. Who's ECNO? Well, what is reg? So making the diagnosis, we are in George are very privileged. We really try to use all the bright people around me, like speech therapists getting a speech assessment and audiogram done, vision, testing the vision, getting the OT involved, asking their opinion. Oh, we use the OTs all the time. And the physios, I don't know, are they dietitians? Yeah, we use them too. Social work, the sisters and colleagues. And what I find very helpful is if I have a complex patient, I would go to Joe or to one of the other colleagues and say, listen, look with me together and let's see if you agree with me. That summary. I just do want to say this, OTs are the best. And it's because my daughter is an OT. So she started working for Shona Quip, who sells these buggies. And this is not an advertisement for them. That's a number. And they started a program where they are paid by Department of Social Development. And this is a work number, and they have started groups. They would visit a town where all the mums with handicapped children would be part of that group and teaching and training them. And then twice a week would be involved with training and teaching sessions of these families. So that's just something to consider. And they do it, they've gone to Nelspruit, she's gone to Uppington, she's gone to the R. So the idea is really to go wide and start these groups where there's on WhatsApp, they give the mums also money for data. So that's one to consider. And then this app, it's fairly new, Rehab Mobile, that's how it looks, where you can, and it gives you, if you open it, it gives you that kind of picture. And if you go deeper, what is autism and what causes autism, it gives you. So it's a very nice for healthcare workers in rural areas to go with. Thank you.
I think that was quite a mouthful. I think it's a topic that we can perhaps discuss whole day. We're going to give the audience a chance for some questions. We've got the mobile microphone. Any questions from anyone? Dr. Breitenbach? Cam?
I just wanted to ask, do you think currently being underdiagnosed by doctors? I know we screen for high-risk people like Down syndrome.
I do think I do think it's under, but we don't see that often too. But if you look at the statistic, we should be seeing it definitely more, statistically speaking. But yeah, so I do believe it is. But we have in our region, I'm talking Western Cape. My impression is certainly that most of the sick kids do reach us and do get to us, and it is not something we identify a lot. but we definitely should be seeing it much more. Yeah. My view is, if you have a child with developmental delay, you have to, because it's so easy to treat and it's really so important to pick up, and the earlier the better.
All right, thank you, Cam. Any other questions, perhaps online? We're not aware of any other hands up on the web. Okay, don't worry, we've got that sorted. Philip, baie dankie. Thank you very much. It was very important. Thank you.
Thank you.